Recording has started and I'm admitting everybody into the meeting. So as people are coming on in, good morning, everybody. This is Dominic Zerlo. I'm the director for the Center for Medical Cannabis and Psilocybin. Welcome to this morning's meeting for the Research and Continuous Improvement Committee for the Medical Psilocybin Advisory Board with Dan Jennings as chair. Just as a couple of housekeeping reminders, we do have cameras off for the majority of people that are on here so that we can ensure that there is enough bandwidth for most people and that they don't keep dropping on and off. We are having some internet issues in one of our locations at the Department of Health. So you will not see the Department of Health staff unless they are speaking. Again, to help keep with that bandwidth. We do have some guest speakers today. When those speakers are elevated to be presenters, just to let you know, if you would like to turn your cameras on, you will be able to do so. I'll remind people at that point when those portions start. And at this time, I will turn it on over to you, Dan, or would you like me to just go right into updates?
Well, actually, what I was going to say is well, thank everybody to come here, but then I was going to turn it right back over to you and say, please introduce your team and any kind of updates from. So yeah, you're reading my mind.
Okay, well, thank you, Dan. So today from Department of Health, we have, and I'm just going to go in listed order, we have some of our health educators, Carmen Batista, Adrian Estrada, and Ishmael Zutat. We also have our medical director, Dr. Robert Truckner. We have some of our support staff as well, who actually is the one who helps us and takes care of all things regarding these meetings, Johnny Mouche. And from the psilocybin program, we have the program manager, Jorge Gonzalez. Let me see who else we have. We also have Leslie Peterson and Cyrus Routman, who are both with our psilocybin team. And then we also have our Deputy Director, Brenda Martinez, here on the line. If I've missed any of our staff, I apologize. And you can put that on into the chat if I did miss someone. And then as far as updates, so a couple of things, some of the big items that are, of course, happening are that we do have the first set of rules, which will be coming on up for the rule hearing, which is set for April 24th. And I'll put that in the chat in just a moment, the information for that. And if you want to read through those rules, you are able to do so. You just can go to the website and read them. And then there's instructions there on how, if you have public comment, how to submit public comment. Just as a note, during any of the committee meetings in the advisory board, comments that are made there are not considered a part of public comment for rule hearings. It must go to the email address that is listed in the announcement for it to be part of that public record. So just to let everyone know, you can still make comments to us. For example, we have a propagation meeting that is next Wednesday. So if you're interested in that, since these rules cover and look at cultivation and testing, you're welcome to come to that and express thoughts and opinions, but they are not a part of that public record for the rulemaking. So if you have something specific for that, please make sure to send it in through email to the email address. It is different than the usual medical.psilocybin, so look in the notice to make sure that you have the correct email. That goes actually to our legal team, and they're the ones who have to compile that. So we do have that coming up, and again, I'll put that into the chat in a minute. I have already put into the chat the list of all the other meetings that are coming up over the next, a little more than a month, going all the way through to May 15th as of right now. And so those are all there, including training and education. That's this afternoon. There is a hybrid meeting for end-of-life care on Thursday, the 23rd. There's also a hybrid meeting for the equity, access, and cultural consideration on the 28th. And so the information for that is also on the program website, and that is also in the chat right now. So if you want to go and check on those, please remember to register for those different meetings just so that we have that list, and we welcome everybody to attend. Other than that, I think those are the main aspects that we have going on right now. So I'll turn it back on over to you, Dan, and thank you very much for the few minutes to provide announcements.
Perfect. Thank you very much, Dominic. Appreciate that. And welcome everybody for coming to our meeting today. And I'm going to give you just a highlight of our kind of 4 beats that we'll have today. So within this 20 minutes that we're starting the meeting with, this is all the introductions and the welcome and such. So to prepare y'all for this next part, I would love for y'all to introduce yourselves. And to do that, just raise your hand. Just use that raise hand button that's up there at the top of your Teams meeting page, and you can get in queue. So we would love to hear from you a little bit about yourself. So we've got about 1 minute per introduction. Just say who you are. I would love to know your affiliations, and if this is a first time for you attending this meeting, or if you're returning, if you go to other meetings, just let us know. We would just love to know a little bit more about you. So please go ahead and get in line and start raising your hands, and we'll do that for the next probably till 9:22. So
All
Okay,
right.
I'll start at the top there. We have Dr. Lydia Fatemi, if I believe. I've enabled your mic. Please begin when ready.
Hi, I'm Dr. Lida Fatemi. I'm the founder of the Conscious Physician Psychedelics Academy. That's a local academy educating healthcare providers in utilization of psilocybin. And I'm also a hospice physician with ABQ Hospice and Palliative. Thank you so much for having us here.
Next, we have Kate Hawk. Kate, I have enabled your mic. Please begin when ready.
Good morning, everyone. This is Kate Hawk. Probably know most of you, but for this meeting, I'll just say I have 40 years as a trauma therapist, longer than that with psychedelics. And next week, I'm going to be working with Sue Sicily and the Scottsdale Research Institute with a group of 8 veterans in their FDA phase 1 study. And, happy to be here as New Mexico develops such a system that we can be a model. Thank you.
Thank you. Next, we have Hannah Rose. I have enabled your microphone. Please begin when ready.
Hi, good morning. My name is Hannah Rose. I'm a BSW student here in Silver City, New Mexico, learning about social work, and I'm also affiliated with the Heart of Earth and Sky Sanctuary. It's where I've had my some of my psychedelic training with. Yeah, I've been working with psilocybin for over 20 years, and just very excited to be a part of this beautiful program and see the faces and hands and hearts showing up. Thank you.
Thank you very much. Next, we have Sam Wolf. Sam, I have enabled your microphone. Please begin when ready.
Good morning, Sam Wolf. I'm an attorney here in Santa Fe with a personal and professional interest in knowing how the rules are developing. Thank you.
Thank you very much for that. Next, we have Caroline Kroland. Caroline, please begin when ready. I have enabled your microphone. And Caroline, just to let you know there, to enable your microphone on your end, you have to click on the mic icon that's located on the top right of your Microsoft Teams application. If that is not working, you can always drop off the call and maybe join back in. That often does help. But you can also check if your microphone is enabled by clicking on the little downward arrow located on the right-hand side of your microphone, just to specify to the computer or to the application where your microphone is coming from. But I will give it a few more seconds, and then what I will do is I'll kindly move on to James Brown. Okay, we're going to move over to James Brown now. I have enabled your microphone. Please begin when ready.
Morning, everyone. Thanks, Dan, again for chairing this. My name is James Brown. I'm a doctor of pharmacy here in New Mexico. I'm a Navy veteran. I'm very passionate about psychedelics. I'm a psychedelic certified facilitator. I'm representing 5 Degrees North Healing Foundation, which is a nonprofit for first responders and veterans with PTSD and other type of issues. Thank you so much.
Thank you very much for that. And before I continue, there's just something in the chat there. Kathy Sanchez, Bureau Chief for Workers' Compensation Administration, Medical Cost Containment. So thank you very much for that, Catherine. Next, we have Gregory Evans there. I have enabled your microphone. Please begin, of course, when ready.
Good morning. My name is Gregory Evans. I'm an independent researcher and home mycologist with no affiliations. I'm a Santa Fe resident, and my intention is to support programs development through committee recommendations aligned with emerging research and best practices.
Thank you very much for that, Gregory. Next, we have Eileen Brewer, I believe. I have enabled your microphone. Please begin when ready.
Hi, everyone. It's great to see you all this morning. I'm Eileen Brewer. I am affiliated with Cluster Busters. I'm an expert in pain and psychedelics, and I've been working on patient education in this space for a dozen years or more. Glad to be here.
It's a pleasure to have you here. Next, we have Brenda Burgard. Brenda, I have enabled your microphone. Please begin when ready.
Good morning, everyone. Thanks for having me here today. I really appreciate all of what we're doing here today. I am chairing the training and education for the medical psilocybin this afternoon from 1 to 3. And I'm so happy to be here to join with everybody to really forge ahead and see what we can do to make this wonderful thing happen for New Mexico. Thank you very much.
Thank you very much for that and appreciate that. Next, we have, before I go on to enable other people's mics, we just have something in the chat there. Mary Hofstad, I believe. Good morning, Mary Hofstad, Santa Fe-based program director for the Modern Elder Academy. Glad to be here. Thank you very much for that, Mary. Next, we have Danielle Leonard. Danielle, I have enabled your microphone. Please begin when ready. And just as an additional reminder, if you want to unmute yourself, you have to do so on the top right using the microphone icon. So just have to click that button. If that is not working, perhaps maybe check on the right-hand side. There's a downwards arrow just to make sure that you have the correct microphone attributed. And if that's not working, simply drop off the call and then attempt to maybe join back. In the meantime, we're going to jump over to James Ferrari, I believe. I have enabled your microphone. Please do go ahead.
Hey, everybody. James Ferreira. I'm affiliated with Ignite Synergy. We have a psychedelic EHR that we hope will help drive this market. I'm also Albuquerque. Been here for a very long time, so good to see you all.
Pleasure. Thank you very much for that. And I'm just going to go right back to Danielle just one more time. Danielle, if you can hear us, just drop a little line in the chat. Perhaps that may be. Oh, we have something there in the chat. Let's just take a look there. Good morning. Sorry, I can't seem to unmute. I'm a therapist based in Santa Fe. I'm also researching with NMHU. Thank you very much for that, Danielle. Next, we have Caroline Crowland. Welcome back. I have enabled your microphone. Please go ahead when ready. Still seem to have a few issues there, Caroline. If you just, yeah, like I said, on the microphone application, on the microphone icon located on the top right of the Microsoft Teams app, you should see a downwards arrow really quite close on the right-hand side next to the microphone icon. Just click that just to see if you are, again, utilizing the correct microphone. And if that's not working, please do present your information and introduce yourself in the chat, and we will read that out accordingly. Finally, though, we have Desba. Desba, I have enabled your microphone. Please begin when ready.
Yat-A, this is Desba. I am chair of the Equity, Access, and Cultural Committee, Cultural Considerations Committee. Just saying hi, just here to hear what's the conversation. Good morning, everyone.
Thank you very much for that. And we have a comment in the chat just by Lydia. Who was the member with EHR? I don't quite recall.
I think that was James Ferreira.
James, there we go. Thank you very much. Well done, Jan. Dan, you have better memory than I do.
Well, that's okay. I've been trying to study every time y'all come to meetings, so.
Incredible. Well, I pass over to yourself then. In any case, that seems to be everyone's introductions done. So I humbly pass back over to yourself.
Thank you very much. Appreciate it. And I saw that we have Tiffany Scott in the chat too. Good morning, everyone. So appreciate you being here. And then we got a few more people that just came in. So thank you very much for putting into the chat box. We've got Ben from nourishcap.com, the platform for all things mushrooms, and Carolyn Crowland. Very good. Thanks for putting it in the chat. Carolyn Crowland, I'm with Fireside Project. It's my first meeting. A pleasure to be here. And I'm really glad that you're here from Fireside Project. So thanks for joining us here. And please hope, everybody, the chat box has like some of the other meetings that are coming up, Brenda's meetings later on today for education and training. So don't forget, if you can, come to some of those other trainings, some of those other committee hearings and board meetings as well. Please, really appreciate that. So again, just to kind of go over some of the beats that we'll have today, this is our first 20 minutes. So the introduction, welcome, and framing. And we're about to move into our next large part, which is about 60-minute block, where we'll talk about intersectional work, presentations, and discussions. So if you remember from our previous meeting that we had last month, we had 3 working groups that were working outside of the committee meetings that we're having here to report back to us on 3 different things: challenging and adverse experiences, emergency preparedness, and patient and community education. So we'll start those in just a little bit. Just to let everybody kind of know how we'll handle those is it'll be about a 10-minute block of presentation for each one of those. And between each one, we'll also have a 10-minute discussion period. During that time, I would appreciate if you would use your chat box in order to ask any questions or to prepare, even if you come across something like, yes, that's fantastic, drop that in there too, whatever feedback you would like. We would like, if there's any kind of questions you have, to drop them in, and during that next 10 minutes, then the team will be able to talk about that. No decisions are being made here. Don't forget, this is simply just presentation. The idea is for everybody to hear and then to see some of these concepts and then to walk away from this meeting so that in our May meeting, we'll be able to have deeper discussions about them. So again, don't take this as this is the way that things are going to be. It is simply the presentation. So I just wanted to level set everybody on that. And remember, everybody's norms, again, is that think large but act minimally, and don't use assumptions. Just ask any questions that you might have. Everybody has equal voice in this at this time. So just really wanted to make everybody aware of that, and be sure. I'm always going to say this as well. Point your things at the information and not to the people. So I'll just leave that out there as well. Then in our next 25 minutes after that, we're going to start talking about convergence and next steps. So what are recommendations that we can give to each one of those work groups for the topics? We'll have owners of that work, of course. And if there's anything that comes up in the chat that might be parking lot issues, we'll put those over there, because it doesn't mean we're ignoring them. It just means it may not pertain to one of these 3 items at the moment, but we'll still put that up there. And I want you to kind of share some of the blind spots that we're missing, some things that we're not aware of that we need to be thinking about, and that can kind of help set our next May meeting as well. So I would love to hear all of those kinds of things during this meeting. And then we'll be able to, during that time, kind of open up microphones and talk about it. And then we'll finish up with public comment and close up in that last few minutes that we have, about 15 minutes. That's kind of the beats we have right now. We're going to move into the intersectional work discussion, and we have 3 groups. The first one is being led by James Brown. I believe that James Brown, you also have Gregory Evans and Danielle Leonard with you on that. So I'm just giving the heads up to the team to allow for their microphones, and you can turn your cameras on if you'd like, and then also share anything. And I will begin the 10 minutes. Like I said, I'm a taskmaster, so I have a 10-minute timer going whenever you are ready.
James, Greg, and Danielle are all elevated to presenters. So if you also want to show yourself or share screen for any items, you are able to do so. And you can mute and unmute yourselves at will.
Thank you so much, Dominic and Dan. We're going to have Gregory present and we will do the discussions. And again, thank you so much to this amazing team with Gregory Evans and Danielle Leonard. Those are the two that are part of this group. And again, they're so amazing. So we really want to start off this discussion and then let you guys know what this group is, that their definitions. There's two big definitions here for everybody. The big takeaways here were the definitions of what's a challenging event and then also what's an adverse event. I think that's really big for the group to understand and distinguish. Let's start with challenging event. A challenging event is difficult in a session moment. When your patient or the person your therapy with is having a difficult session, a challenging moment, again, it should be defined, and that's what we're saying here is this is for discussion, a difficult in a session moment, often therapeutically productive, but it's distinguished by absence of objective harm. And then what is an adverse event? We're saying that adverse event definition would be an outcome involving measurable clinical pathology. And again, that would be with objective harm. And so a challenging event could be fear, grief, anxiety, confusion, side effects, nausea, vomiting, other things like that could be challenging in the moment versus adverse events. An adverse event could be something that is a cardiac event, a serotonin syndrome, which is very rare, maybe an HPBD, very rare again, or a psychotic break. Those would be adverse events. And so that's what we wanted to kind of do. Gregory, your thoughts on this?
Yeah, just really quick, as we walk into this conversation, I have all of our slides prepared as publicly accessible links. Is it okay if I drop those in the chat?
Yes, go ahead. I don't know if you heard me, but yes, go ahead.
Yeah, sorry, just making sure, just getting rid of some link garbage. But basically, there's 3 links here. We're gonna go over what we just discussed, introduction of challenging versus adverse, right? And clarifying that language, which is super important when we're discussing the topic of measuring and tracking adverse events. So with each of these links, if anyone wants to go into those and follow along, they can. If they want to comment, everyone should have the ability to comment directly on those links as well as comment in the chat. Well, I'm just going to kind of burn through this because we are on a clock. My little taskmaster there is nodding his head with joy. Absolutely love seeing that this morning. And James, just butt in if you need to cover something. On this page, we cover our key terms. We also cover some of the deviations that our group came up with that will differ from the current, most recent version of recommendations, and we have justifications further down, and you can explore these tiered instruments. But basically, we have universal instruments, pathway-specific instruments, and then clinician-administered instruments. And the reason that matters to us is we find ourselves all the way down here in the safety and adverse events instruments. And defining those and the parameters around those is something we wanted to do today. There's another call out that I wanted to actually hand this over to James to discuss. I just wanted to address the complex PTSD. Do you want to talk about that for about 30 seconds?
Yeah, what we tried to do, everyone, is as you go through the different ICD-10 coding and the different disease state and the different things that we're going to have to address, a lot of these adverse events were preset by, if we look at the model that's already out there, if we look at Colorado, we look at Oregon, we say, what's out there already? What can we extrapolate? And what can we look at? What clinical articles are out there? That was really big. Is that we went out there and said, what else is out there? And we found a great article by Polinsky that we wanted to share with everybody, that Danielle found for us. Again, thank you, Danielle, so much and so important on that. But with PTSD, I think it's important that the complexity, everybody knows that these are very complex patients and that it's very important that we handle these adverse events appropriately or within less harm, right? So we want to do harm reduction with these type of complex trauma-based patients. You know, they can have very prolonged dopaminergic type of receptor issues. And so what we'd like to do is just recognize that is something that is different than maybe, you know, end of life therapy, that's different than substance use disorder, that each one of these adverse or challenging events should be subcategorized into each, you know, each thing. And so each disease state or each thing that we're treating.
Yeah,
Great.
and on that, yeah, and on that point, like what we're looking at is taking all of the measurements and categorizing them and pointing out that adverse events is definitely down here. The program will be monitoring all of these things and everything is connected. And I just wanted everybody to have a chance to go through this, throw comments in here, come back later. At the bottom of this page, you'll find categorized measurements, the clinical instruments in their categories, and the specific instruments that we currently have available in our recommendation that fall under those hoods. You know, and that way, hopefully, the massive dump of 20 instruments doesn't feel as daunting. But to try to bring it home in our last minute, if we can go over for a little bit, this is kind of a major thing that we're coming with today as far as recommendation. In the world of adverse events, this is very wordy, so I'll try to like just skim through it. But in the world of adverse events, there is not a tool that works for this type of experience. There's a group at Emory University who in 2004 published, I would almost call it a beta version of what is called the PAT-AE. And what this instrument does is it, like what their research paper did was took every existing battery that covered adverse events and they pulled what was useful for psychedelic therapy and built a model, built an instrument from that review. They call it V. Thank you. They call it V0.1, right? And it definitely needs some work. We have a domain coverage gap analysis on that instrument here. And what this shows us is where our department could make it better for us based on what it has, what it's capturing, how it's administered, and what it's missing for our needs. This is something that I'm looking forward to a lot of people like commenting on and providing input.
As Gregory's saying here, this was the framework that Polinsky proposed. Again, as New Mexicans, we want to come up with our own framework, right? So what we were trying to do with you guys is get you information out there that's a framework basis, and then we can modify that, come up with new things, take whatever we want to do to make our own New Mexican framework. So that's kind of the thought behind some of this, is they use a wide variety of batteries, great instruments. And so we can take a lot of these things that are out there and say, what's really going to count for what disease state and what's going to be important. And Gregory's kind of formatted, as we'll show you here in a little while, which one is what, and just to give you ideas. Again, this is our ideas for thoughts. There's that preparation area, dosing session, integration, and then this great thing called follow-up. So that's kind of some of the areas that we were discussing too.
Just because we have zero minutes, I just want to point out to everyone, if you click on these links, they will take you to the actual research papers that went into the Politsky's work. And what we want to recommend to the department officially is that we reach out for a partnership with the domain and help them bring PATAE home by giving it a government regulated program. I think it's a win-win. And that's a much bigger discussion than we have time here for today. But yes, everyone, please enjoy my nerd collections and have a good day.
Thank you both. I really appreciate it again. And all three of you, appreciate y'all being part of this. I'm not going to take a lot of time to celebrate that because I don't want to take away from the comments, but I did have to make that comment. It's huge. It's fantastic. Thank you for putting this body of work in front of everybody. I think it's huge. Again, in the comments, please leave comments. Again, like, I know it's going to be a lot for you to have to read and to digest, but it's very critical for us to do so, because at our May meeting, we can really have some true consensus at that point to move forward with while we do some of the background work intersessionally. Ben, per adverse event, are there any words to characterize the outcome in addition to the existence of such events in other areas of the country? People are assuming the worst from these hospitalizations, even when in fact there have been positive outcomes following. Without additional words or tracking, such events could lead to an really negative characterization. Yes, the idea that we had posed originally was the CATAE, which of course is based on oncology, and it is anything from some mildly upsetting events all the way to very adverse events. But the PATAE as proposed here is a fantastic model off of the CATAE that then does, in my opinion, what you're talking about, is that it characterizes between challenging, that could be healing and growth, all the way to adverse, which is where we really need to look at session issue, whatever might happen to come in there. So unless anybody want to add, and Brenda, thank you, Vital, for education and training, great work. So great, you can kind of take this on to your next meeting as well. I'm going to let anybody else put comments in, but I'll let Gregory and James in the meantime, if you wanted to address anything that Ben had put in there. Maybe what I explained was perfect. I'm going to kind of leave it on
I think
that.
it is.
Okay, perfect.
Dan, and one last thing for everybody, just real quick, is again, challenging events is something that we're going to see most likely all the time as a facilitator. And that's what we want to see. We want to see these people have challenging events. This is where they grow. This is where they get better. And then versus adverse events, I think this is going to be rarities. They are very serious, but they're rarities. And I'm not saying the one-offs, but when they do happen, we just need to have that pathway, that funneling, and then the data to make sure we collect all that so we can improve.
And I wanted to piggyback on that as well, is that before there really wasn't a lot of, we've been trying to find instrumentalities that would help really define that objectively instead of just subjectively. And I really have to say that you all on your team have come up with some wonderful tested, evaluated, and accepted protocols for that. And I know that they didn't get, because of the 10-minute timer that I am such the taskmaster of, this is the reason why it is critical for you to use that link that is there to look at this information, because I know that some from our previous meeting was like, that's a lot of things to do and a lot of time. And I have to say that this team has come up with timing protocols on this, and it's split between in session, out of session, and patient. So therefore the time requirements and the administrative overhead is not as great. But again, please look at those protocols and see how it can help with all four parts of the session and in all four domains of these kind of adverse/challenging experiences. So Danielle, one way to look at it is an adverse event requires an intervention and a challenging event does not. And the intervention is is a continuum as well. What is the intervention? Is it a first response? Is it a hospitalization? Is it long-term? So therefore, you're exactly right. We still have about 5 minutes of this discussion. I'm filling the gap of time. So please just continue then. Ben, then could a hospitalization be categorized as a level lower than adverse, like challenging, or would it always be adverse? The hospitalization, the actual outcome of it is not necessarily what defines in all ways. There are some in the PATAE, you might find things like inappropriate touch is not a hospitalization requiring adverse event, but that's an adverse event. So just know that when you're looking through that, you might find there are certain things that we could flag as an adverse event, or certain outcomes that could be flagged as adverse and not challenging. So that's, but I turn that back over to the work team to steer me if I veered off course.
No, I think that's it's a conversation that we need to have a lot of, and I think the term integration is something that we really need to sit with as we walk into like how we define and how we like structure the, not just the research side of things. This is more of like a global philosophy, but if we really understand what integration is and how that relates to challenging experiences, and where the integration process, that's preparation all the way through follow-up, that is the tool that we haven't been able to measure in standard clinical trials, that changes our ability to really heal from a challenging experience, being faced with something that we may not be prepared to, or prepared to process, or haven't been in a place to process for our whole lives, and then having that brought right in front of your eyes in a very visceral manner, and then having the support and the time to fold those lessons back into your life. And that's what we need to be able to measure to define the efficacy of our programs. And it's not just the medicine, it's the process.
And I appreciate also what you all brought together with the PATAE as a potential partnership between Dr. Polinsky and what we're doing here in New Mexico. So I feel that probably one of the next steps, we'll get into that in the next 25-minute block, but would be, of course, making a reach out and seeing if there's some potential synergy there.
Awesome. And we do have a committee member, I'm not sure if they're here today, who responded to me this morning, and they've worked directly with Dr. Politsky at Emory University. They're a local New Mexican practicing here and contributing to our community committees, and they are more than willing to bridge that conversation. I did want to address Brenda's note about education and training. I have a full crosswalk of committee integrations for all of this work that we put together, and it expands beyond adverse events all the way to like every single battery and how it's going to affect each individual committee's needs to focus on like training, clinical administration, stuff like that. So like not necessarily in a directive manner, but like more of an informative as we all figure this out sort of manner.
Great,
I'll
thank you.
find that link and share that in the chat as well.
Perfect, thank you very much. So we have still 2 minutes for any questions or discussion from this intercession group. So I would love to, if there's anything else, please, like I said, leave it into the chat. And Kate Hawk, Dr. Jamie Beachy of Emory is here in New Mexico, another good resource. Fantastic, thank you, Kate. So I love these meetings. This is how we, honestly, this is how we kind of make network and connections. So thank you so much for this. This is wonderful to have this working group together here. So thanks. So I'm not seeing any more comments. So I'm going to kind of like let us move on to the next group, which is from Michelle Mirabedini, and it's emergency preparedness. I looked through the participant list. I'm not seeing Michelle, but maybe I overlooked. Michelle, are you here?
Yeah. Dan, I am not seeing Michelle either. Michelle, if you might be registered under a different name, if you'll put it in the chat, we can then go ahead and elevate you to a presenter.
Yeah. Okay, I'm not seeing Michelle or anything that's coming up from that. So I do want to, I haven't heard anything, because usually I did ask if there's anything that would come up between, just let me know. Didn't see anything. However, that means emergency preparedness is still a very important part of this committee's work. And so Not to neglect anything that Michelle may or may not have done, but for anybody on this call, I just wanted to give you a little bit of detail, and I would love to see if there might be somebody that could come along and assist with this work. Esba, please raise your, yes. I didn't know if you were, if somebody might be able to unmute Esba for.
Yeah, got it.
Oh, got it.
Yeah, so just in reference to that, I was just wondering if there was like, you can probably put it in the chat, if there was like specific areas in which Gregory or James might note that might have a cultural considerations area to look at, just to kind of see if there was something that from our standpoint might might be not a red flag, but just something to flag for consideration on that.
Yeah, huge recommendation. That's a very good point. And so, Gregory and James, I'm sure if you would be able to add, and it doesn't need to be like a today, but it's between now and the May meeting would be great. And anything in between, if because your link is live, then everybody would be able to see that as well. So, Desba, you might check that link a little bit later on and see if that kind of section, that idea is added there for you too. So, great recommendation. So, for emergency preparedness, we need to kind of set like minimum standards for facilitators and sites and coordination with EMS and law enforcement. We really want to make sure that the psilocybin program is a very safe and effective program, and that clinicians have tools and protocols in place that we can make recommendations for. Again, that way that every challenging experience kind of, I'm going to kind of go back to let's see where it was Ben kind of bringing some of these things up in Ben's comments here, is that not every challenging experience leads immediately to a 911 call and hospitalization. So again, this would be something that could dovetail back into the challenging adverse experiences work that James, Gregory, and excuse me, Danielle that worked on. So I just wanted to make sure that we call that out. So I'm spending a little time at this point because I have a 10-minute time for this. So I do want to ask anybody that's on the call, now that I described what that is, and does anybody have any like background information, work, expertise in kind of this kind of idea, where it would be, again, how do clinicians handle those minimum standards for EMS and coordination and law enforcement? If you do have any of that, please drop it into the chat. Eileen just mentioned, has anyone from LEAP participated? LEAP, anyone from LEAP here? I would love to hear their perspective on emergency preparedness. Thank you. I know Fireside Project is here as well, so I don't know if there might be any recommendations on that as well. So, and I'll kind of then leave it up for James. And if James might be unmuted, then
throw me in with her. With my extensive background in I have a emergency medicine background as well, and so I deal a lot with the EMS crews. I deal a lot with the docs in that type of situation where the first people are going to see them, and then I have some tech in, which would be a great resource to expand that into some of their educational services, and we can work with education on that and getting standards out there as the team develops them.
Perfect.
But those things are very challenging, and they should be handled appropriately with the patient, at the time to go away. And so if we can get 99% of those to go away and addressed immediately with other things like grounding techniques, breathing, other type of modalities that I want to include, those are very important for challenging versus adverse, where you have to really dial up and have bigger responses. But yeah, please include me.
Perfect. And then we have Dr. Fatemi on, and she could be unmuted and share. Thank you. And in the comment box, I did also see that you had said happy to help develop our program.
Yeah, absolutely. And I agree with James. And additionally, I think if we have a call response team where the facilitator, when they feel that they need help, they can call and get advice on what they need to do in this moment, that a challenging experience, and also determine, is this a challenging experience or is this an adverse event? Having that support can help that, it can help the situation a lot. Yeah, that's all I have. Thank you.
No, thank you very much. I appreciate that. And just so you see in the chat box also, Gregory Evans dropped in some PATAE covers cultural considerations. So thank you for sharing that. Desba, you might mention, might take a look at that just to see if it helps in some of your committee work. Shane Daniel, been listening and multitasking, but wanted to mention I'm a PAT integration coach. And if the subcommittee needs perspective from that side, let me know when you're meeting and do what I can help. So I would say that probably, honestly, I'm seeing a little bit more alignment with challenging experiences / adverse experiences and the emergency preparedness side of things. So therefore, I'm happy if y'all wanted to kind of work together on those kinds of things together, because then your challenging experiences, as you're talking about having these grounding techniques and some of these other ways that your clinicians, your therapists, your integrations can work through that, but then all the way into what the adverse experiences look like, and then how the facilitators have standards and protocols and such for how they then engage with first responders and EMS and those kind of things as that might progress. So I feel that might be something y'all might want to look together, maybe bring some more people on board that are coming through here. Then Gregory Evans, additionally, if we were tasked with customizing the PATAE for the New Mexico framework, we can get highly specific with how we frame those needs. Perfect. Hannah Rose agreed, and Gregory Evans, I would say that it still needs work. K-Hawk, having the layer of call support for emergencies and concerns would be incredibly helpful. Yes, that's kind of where we're going, is like the idea of like, when does this need to engage in the first response / EMS / law enforcement if need, and then in regard, having a physician on call as part of this team, taking vitals to ensure someone is not having, for example, heart attacks or seizures. So I'm going to then kind of turn back and ask if for the team, from Danielle and Gregory and James, if maybe you might be able to bring a few more people onto your research team to work on that, to then say, let's take it all the way from what you have created all the way, and then bring in that emergency preparedness piece of it. Would that be something that, I know it's one more thing to add, but would that dovetail well? And please push back at me if you need to, because I don't want to dump more, but I just feel it seems to be a great affinity to do that. Okay, thank you, Danielle. Absolutely. Love to. Can we get contacts? Yes. So again, this is intersessional work. There's no decisions being made at this time. So I feel that if there's anybody on the call that's like want to work with this team that's already started on that, please make connections. I think that would be fantastic to make connections with James and Gregory and Danielle, that you wanted to work together now to expand it into the emergency preparedness. So you guys rock. I mean, this is exactly what I wanted. This is how I think we're going to have an awesome and well-structured program. So really, I cannot thank you all enough for picking this up. So thank you. And that will, I'm going to kind of put an end on emergency preparedness since we don't have any presentation at this time. So Eileen, I'm going to kind of tee you up here because I know you're on the call, and Eileen is going to be bringing in the work that patient and community education, core patient education for pre and intra and post sessions, and also one of the big things that we need to look at is public messaging and community harm reduction in this program as well. So Eileen, if you're ready, they will go ahead and unmute you, and you can also turn your camera on. And if you have anything to share presentation-wise, you may do so, and I'll set you up. You saw, I've got my little timer here, so I'll set you up with your 10 minutes whenever you're ready.
Thanks so much. I am trying to work out how to share my screen. I didn't really put together a presentation, just a document, but hopefully I can do this properly.
Perfect.
Okay, so I really looked at what other people have been doing regarding patient education, because that was sort of what I was tasked with. And I was working alone. So I looked at Colorado and Oregon, because obviously they are the models that we have so far. And how most people are getting education in Colorado and Oregon are through the websites about their psilocybin services. patients are also getting education through the provider websites as well. So much of the initial education about psilocybin services comes from those two places. Both Colorado and Oregon have like vast resources. There's FAQs, there's information about who are approved providers, and there's information like they have videos and resources about what to expect. So that's all the preparation before preparation, if you will. Obviously, the preparation sessions are going to be integral to this regulated program that New Mexico has as far as making sure that people are safe. But if they're reading a little bit in advance, they can sort of self-select as well. In addition to that, the Healing Advocacy Fund, I don't know if anybody from the Healing Advocacy Fund is on this call today, but like they, for both states, put together these amazing client guides that have just tons of information about safety, about what to expect, all of those things. And I have them linked here. I'll put this in the chat afterward as well. So I have them linked here, and I hope that, I know Healing Advocacy Fund has been participating in this process, so I hope that they're willing to put together a client guide for New Mexico once all the rules are made and they know what to say. They can probably copy paste a lot of the things that they've already done. Colorado's also done a public education campaign on social media. They have some in-person and some online listening sessions as well. I couldn't really find anything like in Oregon about that, but I imagine that Oregon did a lot of that kind of stuff prior to Measure 109 passing and Measure 110 as well. But as we know from looking at what happened with Oregon and Measure 110 is that it was ultimately repealed because there wasn't enough public education. There weren't enough public resources for what was happening outside of the psilocybin space. So it's important for us to consider who is going to be using psilocybin in New Mexico that's outside of this regulated program as well, because as Rand has reported, 8 million people used psilocybin in 2023 and 11 million people used psilocybin in 2025. And in 2023, about 10,000 of those people had done it in a regulated situation, and everybody else had done it outside of the regulated situation. And we can expect that, I don't have the numbers for Colorado. I couldn't find them. I'm sure they're out there. I just couldn't dig them up. But we can expect that most of the people in New Mexico who use psilocybin, as they see more publicity about psilocybin, as they see this regulated process come through, they're not going to use psilocybin in the regulated setting. So there's kind of this additional responsibility to do this bigger, larger public education campaign. The approaches in Oregon and Colorado are both excellent. They've done a lot of really great work, but I think that New Mexico can expand on that. I think that New Mexico can obviously use the New Mexico Health Department that already has harm reduction services readily available. But many people are going to be hesitant to access that. We have underserved, marginalized, and historically oppressed populations that are not going to be interested in getting their information from the government because the government has been the ones to oppress them. So there's a fair amount of other resources we can have, but there's also a fair amount of misinformation out there. So I think that New Mexico is going to need to evaluate the resources that are out there and choose which ones will be part of a public education campaign, a PSA or whatever. I've listed here some of the national organizations that do this kind of education. Also on the Colorado website, they list things like the Fireside Project, like Zendo, like all of those things that you definitely want to make sure are part of this process. I love that there's somebody from Fireside on this call today. So we want to make sure that all of these resources are available, but also people have like the knowledge of like set and setting, all of those things. And you can do that through these public education things that lots of national organizations have done. However, if we really want to meet those marginalized populations, we're definitely going to want to make sure that we have local resources available to people who already know how to get into and connect with the communities or are already part of the communities. So like the New Mexico Harm Reduction Collaborative really focuses right now on high-risk substances, but they have a lot of knowledge that we could use to access the communities that are going to need this education and maybe already do need this education and don't have it. There's also the Community Opioid Response Education Program that is great as far as opioid response, but they're going to maybe have some suggestions for this program as far as how they developed a virtual program to teach people about harm reduction in that space. Other considerations is consider how public education can focus on encouraging participation in data collection. There's a lot of hesitance around sharing data, and I know that another committee is working on that, as well as like we talked about data collection here. But I think that New Mexico has a unique opportunity to maybe incorporate that into public education, say why it's important, say how you won't be identified or targeted if you share your information, and say how that could help so many other people if people are sharing their information. And then last, I just want to say with evaluation of outside programs, it might be important to consider if they have good research to back up their program concepts, if they're using fear tactics to say, you're going to think you're a glass of orange juice for the rest of your life if you take psilocybin once, and consider positive language rather than language that furthers myths. Make sure that they have that research to back it up. So that's what I've put together so far, and I'd love to hear some comments. Thank you.
Well, I have to say, Eileen, if you weren't noticing that as you were speaking, you had lots of hearts and lots of claps. So it was fantastic work that you have put together on it. And I think you hit the heart of exactly what we need, we're tasked with in this committee. It is also all of the harm reduction outside of this. So you've already got a great start. I would really love, because again, as you called out, Caroline is here with Fireside Project. And of course, there are plenty of other people on this call that probably have a lot of affinity in this space too. Eileen needs you. Eileen needs your help. So I want to use this next 10 minutes of comments to kind of have y'all kind of talk in your chat box, like share so that Eileen can bring you into this work, because in the next 25 minutes, we're going to talk about next steps and such. So Eileen dropped. I missed Dr. Fatemi. Thank you for missing the amazing meeting to teach integration to our academy students. Go for it. Thank you. Eileen dropped the chat in the chat box, the link to this doc, so you can see this offline. Kate Hawk, happy to see the realistic comprehensive approach to education. Wondering about supporting quality drug education in schools. I run substance abuse prevention programs for students. I think that this is going to be as exactly what Eileen had called out, is like, when we're talking about public education campaigns, are they based upon reality or are they based upon negative language and fear? Our job is to ensure that if there are community education and school education programs, that it is grounded in reality and not in those things that we just mentioned. So please, I would love for people to, and we've got 10 minutes. So if you do feel like I don't want to type it all, I want to raise my hand, go ahead. We've got some time. We kind of accelerated the time. So anybody care to kind of share anything that Eileen has brought to the table here, and especially who wants to team up with Eileen on this, because there's a lot of kind of next steps that she's outlined. I keep monitoring. Oh, there we go. Thank you, James. Please, I think that you'll be unmuted and can share.
Eileen, amazing work. Thank you so much. Question for you on this. What do you think are best social media? There's so much stuff about social media platforms. What's our biggest push here? What do you think out there right now? Kids use one thing, adults or people are going to be using another thing. So where do you think the DOH or everybody should your thoughts on what's our biggest opportunity or focus point that we could go after with that? What's your thought?
Are you asking about like what platforms we should focus on, or are you asking about like what strategies we should focus on? And yes, Caroline, I see your comment in the chat. I would love to connect with you as well.
A little bit of both. There's everything out there right now, from Facebook to Instagram to lawsuits to so many different opportunities here, that money, time, and spent's going to matter, like you were saying. So kind of a little bit of both.
So that's kind of a long answer, but I'll try. Okay. I just got a master's degree in communications. I'm excited. I get to use a little of my knowledge. Really, picking a social media platform depends on who it is that you are trying to attract. If you want to attract 40-year-old men, you want to use YouTube. If you want to attract 14-year-old girls, you want to use TikTok. So we want to attract, if you want to attract people who are me, you want to use Facebook. We want to hit on everybody, and there are programs that you can use to cross-post messages on multiple platforms. However, it's a little more complicated than that, because what is going to make me read is not what's going to make my 14-year-old daughter read. She does not care about the language that I would use to talk about things. So it is going to be a little of trying to create resources that the demographic is going to connect with. And what I connect with is not what a person of color is necessarily going to connect with. And when in New Mexico, there's a large Native American population, and they may have more education on these topics than we do, but how we connect with them is going to be very different as well. So unfortunately, yes, time and resources and money is all a factor. But unfortunately, if you want to reach all of these different groups, it is going to have to be a multimodal approach to reaching it. And then what you say is also going to have to change based on who you're reaching. There can be some basics though, like just 10 points, like set and setting, like considering your other substances that you're using at the time, like having a trusted care partner who is sober, having a sober sitter. There are like bullet points that you can hit, and then just how you say it to the different audiences changes a little bit. I hope that answers you.
That was fantastic, Eileen. I appreciate it. And I'm glad that you called out some of the equity work, that DESBA can definitely kind of like dovetail in some of this stuff with as well. And also during your presentation, you're calling out the fact that some of the trusted messengers in this, of course, Department of Health would be a trusted messenger. But again, would it land for every kind of message? And it may not. So therefore, having other trusted messengers in this system is very critical as well. And you outlined several that are out there. So fantastic work. Next one that was up is Hanaros.
Hi there. Yeah, thank you so much, Eileen. Really nice to hear your perspectives about education. And what came to mind while listening to you and listening to this last dialogue is asking ourselves individually, how do we want to show up? Are we more inspired to connect on a local level and make an impact locally, or on a larger scale? And so my curiosities are around having an education aspect of the medical psilocybin program, and what would that look like? Also around partnering. You mentioned some organizations, Eileen, partnering with these organizations. So if we had a really organized resource-based resource document that even broke it down, like how do we want to make an impact local, and then it was organized on a local level, bigger scale, then we as participants in this program, however we're participating, we can know how to take action and make an impact. Thank you.
I think those are such excellent points. And the good news is that some of that work has already been done. Students for Sensible Drug Policy has like this master list of resources that is so comprehensive. The only thing that I think that we would have to add to it is the state and local resources that might be unique.
And
I just think it's such a good point.
Eileen, I think that would be great. If you do want to move down that pathway, then that's one of the asks that you can make of the committee, is to say like, okay, this is a gap that we have. Doesn't have to be all on you. It could be like, you can like outline it and then just say, here's the gap. That's part of the next step. So yeah, you're not on your own on that. So, and then Hannah, back to Hannah on this one.
Yeah,
And then
one
we'll
more.
go to Gregory.
Thank you. One more quick thing. As somebody that has extensive training in nonviolent communication and authentic mindful communication, I liked that you pointed out deconstructing and using mindful communication around this. And that doesn't mean that just because we're here on this call and in this meeting that we know how to do that. A lot of our communication patterns are really embedded in us. And so I also like the idea of having, a training program within the medical psilocybin program on how to deconstruct these limiting belief language and thought patterns and self-reflect. So we know, oh gosh, where am I holding these assumptions and biases and limiting beliefs as well? So again, thank you, Eileen, for speaking to that.
Appreciate that.
So much more eloquent than how I said it. Beautiful.
Hello, Gregory Evans. I'll let you come up next, and then we'll go to Desmond.
Thank you, and very glad to see the work that you put together, Eileen. My contact is on some of the stuff from earlier, so feel free to reach out to me if you want assistance organizing and like preparing things for dissemination. That's just an open door that can be for universal for everyone. What I was really curious about is, do we have anyone from the department's training in it, like the education team associated with this program? Do we have anyone in there that can like be partnership level, not like kind of interstitial work with those teams that are in place and should be actively working on this to collaborate? Like, do we have those relationships mapped out?
That's a good point. I think that Dominic, you mentioned that there were educators from the department here too.
Yes, so a couple of items on that is we actually have 4 health educators and a program manager within our center, and they are working on educational material. It was really great to see all of this information from you, Eileen. For those who are here who have known me for many years, and there's quite a few here, one of the things that we look at is to ensure that we have harm reduction practices throughout. And part of the reason why I can help and guarantee that those sort of things will happen is because if anybody here has actually gone through the New Mexico Department of Health harm reduction training at any point, and I just kind of like to see real quick, Desba, I know you've got your hand up to make a point, so we'll keep that in mind. But if you can raise your hand real quick, who's gone through that training here? Okay, some of our staff, but nobody else. That's actually a training that is offered throughout the state. And part of the reason why we have some of our staff who have gone through it is that training was actually initiated over 15 years ago. And I created that curriculum and continue to help with them. I used to manage that program, and so for those who are not familiar, it used to be the Medical Cannabis and Harm Reduction Program. And so we ensure that those sort of aspects are included within it, and we'll continue to do so. So yes, we do have the expertise already within the center. We work with the harm reduction program on a regular basis, talk with them about different trainings, educations, and to be able to do this. And so, yes, we are here, and it is a part of what we're here to help with. But remember, right now, part of these committee meetings are actually to hear from the communities, and we don't want to overshadow that. And so that's just one thing to remember, is we're here to help, and we will help. And there's no question on that side. But we also want to ensure that we don't inhibit what the communities and different people want to bring in, and ensure that they're bringing it in without us simply turning around and saying, oh, we're going to do it this way. And I hope that helps with regard to that.
Thank you very much, Don. Appreciate that. And it's good to know that we've got a team that's behind us on that. So Eileen, as you and your group kind of come to this, then like I said, you're not alone. Brenda Bergard says possibly need to have social media specialists. And Eileen, I haven't been in New Mexico, but I've gone through the training. Desmond, I know you had your hand up, and we've got, and then I saw Dexter raise his hand, but or Dexter, I saw you raised your hand. I want to make sure, Des, but did you have comment? Please unmute if you can and need to.
Yes, thank you.
Gotcha.
Thank you, Dan. Yeah, so just a couple of notes. This is also to the general public in the meeting, and then also speaking to the choir with the DOH type of deal. In my understanding, government work is very limited and based on budgets and what they have the capability of in place, but then also with the recommendations that we're going to be providing to them on the specificity of how in particular psilocybin education. And thank you, Eileen, for the note on the Native American communities. And then also Dominic pointed a little bit to this just a second ago about, whether or not how we're going to go into these communities and how we speak to them and how we are able to address their issues. One thing I just kind of wanted to point out and keep in mind, again, this is just for the general public, is, we have a lot of this way of speaking, especially in the psilocybin communities, about our mindfulness, about our practices, and about alignments, and about, we have we've kind of sort of created this other type of way of communicating. And sometimes when it comes to communicating with the masses is to keep it simple. What are the most common ways in which we can bridge understanding that is not harmful, that is more in alignment, that is in ways that specific communities might be able to understand? And some of these communities that we are going to be educating in addition to might be more on the religious side, might be more on, I would want to say opposite, but not always the case of our own way of looking at the world. And we have to be mindful of how we're coming off of being overly righteous or overly knowledgeable about this, what we're doing and how we're doing it, but really to be in a place of listening, as Dominic was saying, like, what do the community need? And especially as Eileen pointed out, this government, essentially, how are we looking at it when it comes to marginalized groups have been oppressed by the government and also by colonization over hundreds of years? What does that look like when we're trying to say, here's the pathway to freedom? Great, wonderful. But it's just like, here we are prosecuting and completely running over these types of communities. And now we're saying, here, let's show you a pathway forward in this particular safe way. But yes, I really appreciate Eileen's pointing that out. And it also, I feel like the recommendation specifically might be to have someone that might be more on the what does that look like on the other side of things. And not saying that the Department of Health doesn't already do this with their websites. I'm mostly on Facebook, so that's what I see is, that outreach. But what I'm hearing from Eileen is, this really has to be targeted if we're going to be able to provide it for, these multiple social media levels, and also multi-generational, but also just, cross understanding between different varying levels of education, spirituality, everything, and every single spectrum. And what does that look like?
Well, thank you very much for that, because it is so important to bring this work into that. So love that you call that out. And I think that that's one of our key critical points, is to work very closely together, as you said before, to make sure those messages reach well. Got about 2 minutes. I do want to make sure Dexter gets in before we go to our next point, which is convergence and next steps. And then, so Dexter, if you would unmute and kind of share your comment in the next 2 minutes.
I think I'm unmuted. Yeah. I'm a veteran, and I think the veteran community is a unique group, and therefore I would love to have training or collaboration with any educational group, and I'd like to know where to start. Who would I reach out to?
Are you talking about general education, or are you talking for facilitator education?
Specifically for the psilocybin program. I know I would love to get an early start in helping veterans understand what to expect when this is finally rolled out.
I see. Perfect. Yes. Thank you, Dominic. I was going to say, please, I think you don't.
Yeah, thank you, Dan. And thank you, Dexter. One of the things that will be happening as the program gets established, as the rules and regulations are put out there, then we'll be conducting various outreaches and various educational sessions for different groups and individuals. And veterans are, of course, one of the primary groups that we'll be reaching out to, as well as Native American and other marginalized communities, because we do know that there's a definite need in those areas. So we'll be doing that. What I would say the best thing right now, because those plans are not in place yet, because we can't really start talking about it until we have, the rest of it, as far as where are people going to be able to get services, more information on it. And so for right now, the best thing I would say is keep watching on our website, attend some of these meetings, because as that information is available, we'll be putting it out there. And definitely there will also be trainings for people in the public on how they can help with outreach as well. So I hope that helps with regard to that.
Thank you.
Yeah. That's perfect. Thank you. And Dexter, just to say this also, because Eileen is working on patient and community education, very close. And maybe if there are certain aspects that you can share and bring into this as well, just as Desba mentioned, that there are different audiences we need to be mindful of, please, bring your expertise to this as well. We're moving in, and I apologize, James, I'm going to get your comment that you read and then probably catch you back up again. We're moving into our last kind of a little bit here. We do have Hannah Desba. Yes, cultural sensitivity is essential, and this requires education on our parts about what this means, how to serve with cultural and sensitive embodiment. James said we need to have a pairing of integration focus with education of the public. And Hannah, back again, this is a pinnacle of social work practice, and maybe there is an opportunity for partnership and education with the social work profession, the medical psilocybin program. Fantastic comments, everybody. And we're moving into now our convergence and next steps. So there's a couple of things I wanted to hit in this one, just so we can wrap this meeting up and say we've got some action that we're working forward to and what our next steps are. So we do want to talk about, for each topic, what are 1 to 3, and probably 1 is great, recommendations for each topic, meaning the challenging adverse experiences, what's one of the most important things we need to do next. For emergency preparedness, what is one of the next thing that we need for that? And then for the patient and community education, what's one thing we need for that? So for each of the committee, or the subcommittee groups that have ownership of this, I would love for you to kind of just say, like, this is what I need, meaning It's like, this is what we're going to do, or what I need from the community at large here. And let's see if we can get some help from the rest of this group here. Also, in this time, I do want to talk about any parking lot items or blind spots, things that we're missing. But essentially what this 25-minute period will be is, what are the interstitial groups' next steps, and what can we come back in May with, to especially, I want y'all to be able to kind of come to some consensus on some of their work, so that we can move forward on that, to say, yep, this is perfect. Let's move on this and let's continue on this. So this is for each one of y'all that had work in the group. So of course, James and Gregory and Danielle, I want to make sure, and Eileen, please kind of share on that. 1 or 3 kind of topics that you need help with, or you're moving forward on between now and May 8th. And this is an all skate. So any of y'all, there you go, James, go for it.
Hey, Dan, for our group, and I won't talk for everybody, and again, Gregory chirp in here. Definitely that cultural sensitivity and access type of thing that was brought up. I think that will be a focus of ours, is encompassing that. Ideas like that group. What else were we missing, and are great ideas like that cultural sensitivity and other things?
And Gregory, I think that for your group also, you had mentioned that maybe reaching out to Emory, and I believe I saw some kind of work on that too. Is that one of the next steps y'all have as well?
Well, I think, you know what, I have a whole document on that pathway.
Yes.
For connecting. But I think what we specifically need is the program approval, essentially. Like, does the program want to explore this conversation? And do we want to approach it as a partnership, or do we want to take the domain and own it separate from the Politsky publication? And then, yeah, then after that, we reach out through official, like, we can have soft conversations, but there needs to be a decision of who in the department or in the board does the official ask and starts that conversation.
I'm going to make a recommendation again. My recommendation triggers that. So I need, as anybody's pushback on that. I think that personally, like a soft contact would be great, to see if there is some kind of, like, this could work. We won't know exactly what that looks like. And I feel that maybe for our May 8th meeting is that you can present kind of a proposal of what that would look like, whatever. And it might be, here's 2 different paths or 3 different paths of what that might look like. And then that way we as a committee could then make that vote as to say, this is the one to kind of go down, especially with the advice coming back from, Dominic on this and the rest of the DOH team. But I think that would be I think that would be a solid next step if y'all could make that soft contact. What do you feel? That's just recommendation.
Yeah, definitely. And we'll, like, that'll happen shortly. And I think just including all of the people that are in the conversation in that. But I think we need to understand that the idea is that we are creating an instrument that does not exist. And that means something on a that is a massive thing. Like, we're still using instruments designed in 1916.
Mm-hmm.
Over a century later, in this work, we're still informed by those instruments. So by doing this, it's massive. But outside of that, I'm still kind of collecting my thoughts about what we need contributions wise for interstitial work. But
okay,
there's a lot.
Yeah. And I think, because again, it's just like we're taking this elephant one bite at a time. So this is their, just, you've kind of got a great outline for everything. And that way you can say that this is kind of the next sprint that we have for this. So from the aspect, I'm glad everybody's kind of sharing contact information to do this work offline and to support and help in this, because this is a lot of work. You're exactly right. We can't get it done in the 1 hour, 2 hours that we have these meetings. So, and you can't do it by yourself. So James, thanks for bringing up if you do need to work with DESBA on anything on the cultural side, please definitely make that contact as well. I think it's huge. I think that makes a big thing. And then for Gregory with the contact with on the Plisky side, and then coming back with like, here's the pathways that we can go down with that. Eileen, for your, and of course, I'm sorry, because emergency preparedness, I know that was one of the things that I've asked y'all to take on since it dovetails well. So anything on standards for facilitation and sites for working with the protocols, EMS and law enforcement, especially on the adverse experience side and such, and where we could go in that direction. And then Eileen, how about you? What kind of next step do you see between now and May to work together, and what help and what support do you need that maybe this community can help with? And I need people to say like, yes, I can help Eileen with that too. So.
Yeah, so got so much great feedback. So I took notes in the document that I prepared. So I want to start to build out some of these other suggestions that people have, like drug education in schools. I want to start to look at like what's being done and what could be done. But one thing that I really want to say that I need a lot of help with, because I work primarily in the pain space where the preparation, administration, and integration sessions aren't really as much of a thing. I don't know a ton of real information about integration. Like I know what my practices are, but that's a N of one. If anybody could join and help with the recommendations for the public education about integration, that would be like massively appreciated.
Thank you. And I'm going to throw out a name just because I've known Catherine Warnock, but that's somebody that I feel, and if anybody is out here on the call that has contact with her, maybe that might be somebody to connect Eileen up with. That's a recommendation, doesn't mean anything else besides that. So, but anybody want to kind of share if I'm on the right track, or if you've got another recommendation to connect with Eileen?
I think that would be a good one. I can probably do the connection if there's no one else that's
Perfect.
There.
Thank you.
Yeah,
I was going to say Brenda and Jorge got to see too.
Oh, yeah, Brenda's here, so maybe she can refer to that. I'll go ahead, Brenda.
Thank you very much. So yes, I can definitely connect you, Eileen, to Catherine. We do converse a lot about what education looks like, along with other people out there in the community and other teachers that have been out there. So yes, definitely I can, I got your email address, Eileen, and I can go ahead and email you Catherine's information. And actually she's going to be the speaker today from 1 to 3 today in my training and education. So yes, I really would love to see more and more people get together about forming the curriculum, what that's going to look like. Like Dan, you're doing such a wonderful job with moving everybody together.
I'm not doing
to do any heavy lifting here. This is just phenomenal. So
agreed.
The experts are out. Y'all know that. That's all I could do is think about is like when you're in a symphony, the conductor's just doing this. Everybody's actually making the music. So that's what y'all are doing.
The thing is that clinicians really who have already have certification and training are chomping at the bit to start to practice. And even though that a lot of us who have been practicing, who've been teaching, we are used to the protocols, the history of New Mexico, integrating that, what that's going to look like for culturally speaking. I think one of the main things here is that this is really great because we're really getting into the details here in your meeting about what this is all going to look like, but everybody's just, getting ready to make this leap. So thank you very much. And yes, again, Eileen, I will connect you with Catherine. Thank you.
Thank you. And I'll be at the session later today because I really want to hear. So I'll be there.
Thank you.
Awesome. And Dr. Truckner, I see that you had unmuted your microphone and went back on mute. I wanted to call out if you did need to say anything, and I've been talking over you.
No, I am fine. Thank you very much.
Okay, no, I just saw you come off mute, and I just didn't want to like ignore that. Okay, thank you very much for that. One of the other things that I've run into, so I think that all the groups kind of have at least, you've made connections, which is fantastic. You've got people that can help you with your next steps. Absolutely love that. And I'm going to hit a couple of comments in here that I missed here. So Eileen did put in contact information. And please feel free to reach out if you need help with recommendations, and feel free to comments right in that document shared. James shared his contact information. Hana Rose integration is a vital part of effective psilocybin healing. This is an area I know well and would love to share with you, Eileen. So I'm glad y'all are kind of sharing the contact information there as well. And that's now been placed in there. So awesome. The other, so I love it. I love, like I said, y'all are the ones making wonderful music for New Mexico, and kind of go back to Eileen's point about there's some wonderful work in like the Zendo project, Fireside and such that's out there, but we need to make it very specific to New Mexico. Gregory called that out as well. The idea with utilizing some of these techniques that is going to grow a wonderful New Mexico program, and kind of just, I just got to share. It was like, I really want this to be like, I want people to go, man, New Mexico knew exactly what they were doing. They built a program that is not just, we've got psilocybin out here, but it's like, we've got a safe, we've got a homegrown program, something that the rest of the country is really going to look at. So I'm so excited about the work that this group has been doing and sharing, and the expertise that y'all bring to that. Caroline Crowland, I'd like to note the executive director on the Fireside Project will be joining the next meeting to discuss our organization's work in the space. I love it. So that would be fantastic. I would love, as y'all are working on that, because again, this would be a great, when we do this intersectional breakout again, that would be a time for the executive director to kind of share along with Eileen at that time. So y'all kind of coordinate that as part of the presentation. I would love that. The other thing that I do know is that, like I said, what both Eileen has shared, what Gregory has shared with James and Danielle, those documents, please, please, please review them between now and May 8th, and come to the May 8th meeting, because we'll spend some time at the beginning of that meeting talking about that work and any kind of issues that anybody might have, questions, comments that anybody might have. Because what I would like to do is to, again, revisit some of the protocols that we had agreed on before, and make those changes that that the team has kind of shared. Eileen shared a lot of great resources, and of course the James, Danielle, and Gregory team shared a lot of resources. I want to make sure we can update that as well. So we'll be able to converge that too. And then with some of the time that we have left in this beat, we've got about 10 minutes, parking lot and blind spot ideas. So again, this is a time, this is research and continuous improvement. So I need everybody that's on the call to kind of share anything that is outside of the topics that we talked about today, or like I said, blind spots that we really need to work on in this group. Because, and if you do share something, I hate to tell you this, but because again, I was a teacher, usually when somebody asked me a question, I said, great, you're the one that's going to research that. So I'm just calling that out. Probably nobody's going to say anything now, and I don't want to do that to you.
Don't threaten me, Dan.
I know somebody's going to be on the call going, oh, I'm ready, I got this. But for this group, and again, focus on what we can do, what this group can do, because there's other committees that are doing other work. But if that is something that is cross-pollination, but we can definitely make sure the other groups are there to hear what you might say. That's kind of what the parking lot idea is for. So yeah, start raising your hands and let's put some stuff in the chat. And so Desba, you're the first one up.
Hi, Dan. So yeah, I kind of will make good on your suggestion there. Just a quick note, I think that for the sake of kind of not overdoing everything, I did take a quick glance. I'm on my phone too, by the way, so this is a very quick glance at the flagging area where Greg and James's presentation was for the sociocultural issues that might result of that. I think that for the sake, again, of kind of, and this is for everybody else too, who, if there's anything in particular that might be on the cultural considerations axis, etc., kind of maybe flagging that in a copy paste way where that one can also be in its own sort of parking lot for uh, the cultural considerations aspect of it. And then I want to just say maybe specifically, parentheses Native American. And the reason why I'm saying parentheses Native American, because we do have other considerations that are cultural here in specifically New Mexico. It's a very, very diverse. But since we do have a large population of Native Americans, and I do have people who are asking specifically for what that looks like for Native Americans and specifically for federal tribes and their sovereignty. And the reason why saying copy paste and put off to the side as like kind of almost a separate document with these social cultural considerations is that way if there is a website, which will be my recommendation perhaps to the department if there isn't one already that I am aware of, that tribes can go to, that these nations can be able to just, quick tab look at what these things might be. Because sometimes it is just a matter of, I do look for those kind of quick tabs. I do look for the information that might be specifically targeted to a specific group, such as myself. And so I think that it might be helpful for the other committees and anyone else looking at that to just maybe have it set aside that these are the ones that we feel might be flags for cultural considerations, maybe specifically Native American uh, tabs for whatever they're looking at. And I'm going to keep in mind for May 8th because my committee is on the 28th.
Perfect. Thank you very much for sharing. I'm glad that you got that out to everybody because that's a perfect blind spot that we've got to kind of hit. Gregory, you're up next, and then over to James.
I think to what Desba was saying, if we, because I don't want to spend any more time talking about the Politsky thing, but if there is a team, I think having a representation from the committee, probably having Desba involved in that conversation is a great way to approach those modifications. But okay, number one, I've said it before and I'll say it again. We need to include chemical fingerprinting research. Like this work group has primarily been focused on getting instruments and measurements on the therapy and the program kind of outputs, but what we're not looking at, and what I would like to at some point when it's appropriate, start to look at what the chemical analysis of the medicine is and how those unique fingerprints can layer into specific types of therapy. We have like our 4 main channels, and let's figure out if there is nuance that we can do to amplify and specify types of medicine. That's one. I also think that we can parking lot and probably bring it in sooner than later. The integration of the end of life research, because I think that's kind of a gap that we're missing in the data that we're collecting. So I want to kind of mark that. I want to make sure that we start to track, or we build in the infrastructure to track participant dropouts, where people drop out of the program and why, and if there's not a reason or whatever. And then that brings me to like the other conversation around the infrastructure and the tools that we're going to be using to collect and disseminate this information.
Great. Thank you very much. I put all those down on the parking lot idea because those are great, like next actions that we can look at for our next meeting too. So fantastic. And then James.
Hey, Dan, one idea that I had, just one thought here, because I haven't heard it yet, kind of goes back to the education side, is really the difference between a medical model and a recreational. What language, we need to be very careful My experience again is that once we announce this, it doesn't matter what language we use out there. People are going to even be more curious and be more willing to try this themselves. And without really saying, you only can do the medical way. How are we going to do that? I don't know. It's a bigger question for the DOH, but that's a big thing, is we don't want to channel these people to the recreational side. We want to channel them to the medical side. And that's going to be a big challenge and a big step up. And the way we word that in education and just follow through, I don't know. It's going to be something. I didn't know if there was thoughts or ideas because I just thought that was something we hadn't discussed yet. Thank you.
Personally, I love that. And the nice thing about this is we've got a couple of minutes left on it, so I get to have a few comments here. But that's great work on Eileen's, working group as well. And now I'm going to throw it over to Brenda.
Well, thank you, James, for that. Yeah. So, what would recreational look like, with the medical model? I think safety is always the best way to go. I mean, once you put the safety out, it's really up to the individual who is going to do that on their own. Education and safety is paramount. It doesn't matter if it's medical or recreational. Safety is always paramount, and that's where Fireside comes in. There's the number to call if people are running into trouble, because as human beings, we like to experiment and we like to DIY a lot of things, and we don't know exactly how much trouble we could get ourselves into because, a large part of us are risk takers. And for example, I was talking to a nurse the other day, and she she does do things recreationally. I'm not going to mention what she does, but the thing is that everyone doesn't really know about this program. And when I was talking about it, oh, there's a program for this. It's like, yes, there is. And I have to remind myself lots of times, James, that a lot of people don't know what we're doing here, even in our own backyard. Yeah. So it's very interesting to see how we're going to disseminate this information and get it out there to the public. As you know, the president of DCRIM for psychedelics for here in New Mexico, it's just basically just like kind of just a holding spot right there for people to start to know that there is something out there. However, I think people are just laser focused on social media and not and just taking bits and pieces and cherry picking here to see what's going to happen. So yeah, back to my main point, safety is always the best way to go. And we don't want to push one way or the other, but we want to make sure that people are knowledgeable on whatever route they're going to take. Hey, be safe out there.
Perfect. Thank you, Brent. You're exactly right. And like I said, that's the work that Eileen and the rest of the people that are helping with Eileen's going to be really focusing on those kind of messages. I'm going to, since we're at the last 15 minutes, which is now the public comment and closeout, everybody keep your hands up that were already had your hands up, because this is now moving into your time where I really shut that up and I'm not going to talk. But Shane McDaniel said, if you want a good contact for integrated coaching, I recommend reaching out to Being True to You, Transformation Coaching and Training, and the link is there. So true, James. Thank you very much out there. And so now we move into public comment closeout. We're going to reconvene this group May 8th at 9 o'clock to 11. So make sure you mark on your calendar. I really appreciate this group and the same consistency that y'all have been showing to coming to this. And that'll be, of course, the interstitial work will come over to this. If anybody has Michelle Amir Bettini's email or contact information, because they might want to get in contact with Gregory, James, and Danielle, drop it into the chat, or anybody that can get them in connection would be great. And so I'd love to see you all back at that May 8th meeting. And if you have to drop off, completely understand, but this is now your time. This is public comment. So make sure that if you would like to make a public comment, keep your hands up, and then we'll open your mic for you for the last 13 minutes. So Desma, you're up first.
Hi, thank you, Dan. To James's comment I just wanted to point out too. Yeah, we definitely the specific concern that we have for this particular program is the medical, and I think that the DOH will figure out what language. It's kind of almost like a branding. We have DOH has to be on brand for what they're uh how they're doing it, how they're conducting, because it's restricted by the program that is being rolled out. So when it comes to whether or not people are of their own volition reaching out and doing the recreational, yes, Brenda's point, it does, the websites could definitely be more broad in its, these are the recommendations we have, is that maybe it's more broad, and to just not forget that the DOH should not forget that it might be more broad in what possible um connections that might be made. I don't know if they can do connections to Fireside. I don't know if they can do connections, or these are the hotlines that you can talk to in that way, but maybe that might be a recommendations, or here's some other avenues if you feel like you are crisis hotlines. These are types of the things that people can, and that these are also not these are private organizations that are doing their own things that are not associated with the DOH, because those are things that are definitely going to be into consideration. And I'm only saying that for the sake of the public, that it's almost like there's two different things. There's the branding, and I mean that's very loosely. I'm not saying that that is what the DOH is saying, but the DOH has a very specific concern for medical psilocybin, for where we're at. But I think it's a good point that for the instance of education, what does that look like? Because people are going to ask, what's the difference between medical psilocybin? What's the difference between psilocybin in general? And what's the difference between magic mushrooms? In essence, it's basically where it's coming from, I think, is kind of what, maybe the education part needs to come. The medical psilocybin is coming from these specified growers and cultivators, et cetera, that is being facilitated through these particular specialists. And that's all. And then, that might be leaving that gap where, say, the Organization for Decriminalized Psychedelics New Mexico might then fill that gap. Then there's all this other stuff. Then there's all these other things. If you need more information, these are the places that you can go to. But I think that for the sake of understanding, for the general public, for ourselves, we just kind of keep those things in mind. That there is the government side, medical psilocybin, through the facilitators, through these networks and these channels, and then there's everything else. And we kind of sort of don't talk about everything else, but we also do provide
Thanks.
safety in that
Thank you,
sense.
Desmond. Appreciate that. And Gregory, you got 3 minutes.
I just wanted to walk through some language that I heard there, and focus on the definition of the program being exactly that, like the structure of what the program is the medical application of this thing, right? We're not trying to take the thing away. All of the decrim efforts, this should support that, hopefully, But when people enter the program, it is the pipeline of the full healing model. So you enter, you do your onboarding instruments, you kind of say there's a software model that allows you to construct your identity in the program, and then select the people or the practitioners involved in facilitating that experience. And this pipeline covers months and years. We have instruments in here, especially for some of the more edge case conditions that span up to 5 years. So that makes it very, very different than going to the park with your friends or on Bicycle Day, which is coming up. Everyone can remember Bicycle Day. and celebrate that in whatever way you choose. But it's like the medical pathway is a very specific way to interact with this medicine. So yeah, I don't know, just thoughts.
Great. Thank you, Greg. And anybody else have any public comment to make? Great. Dominic just dropped in a couple of things into the chat. If you did have a public comment, please raise your hand. There's the information about all the next committee meetings and board meetings, also how to submit public comments for the program, and then how to submit any kind of document sources, websites as well. The documents are there, the comments and everything for that. And if you want to provide public comment regarding the proposed rule, there is a very specific email address and very specific postal address to send that to. Also, the notice of public hearing and the full text can be seen at the website provided. And also, because this topic is being raised about things NMDOH should do from an education standpoint, here's a link to the materials that the center has for cannabis. We anticipate developing similar education programs as the medical psilocybin program develops. Great job, everyone, and things moves along, seems like. Again, we've still got about 7 minutes left in case anybody did want to share any public comment. And you can even drop it in the chat if you need to. And I'm not seeing anything. So, of course, I don't like to just say, okay, well, that's the end of it. So everybody have a great day. But respecting your time, if there is any public comment, please share. If not, please, I really hope you have a wonderful rest of your Friday and great rest of the next week. And I'll see you again on May 8th. Don't forget, there is Brenda's meeting coming up here, and it sounds like it's going to be a great one to be there. So please, Eileen says, I just want to say thanks. My inbox blew up. Great. That's exactly what we wanted. This is where everybody gets to work together. So thank you all very much. And thank you, absolutely. Appreciate y'all's time here today, and we'll see you back on May 8th. And thank you very much for working groups. You guys are awesome. I can't thank you enough for that.
Thank you, everybody. Have a great weekend.